Welcome to the American Association of Critical Care Nurses Voices in Nursing podcast, exploring critical care nursing through meaningful and inspiring conversations. This episode is sponsored by AACN's certification, offering specialty, subspecialty, or advanced practice board certification, with information available at www.aacn.org/get certification. Now, here are your hosts, AACN's Chief Clinical Officer, Dr. Vicki Good, and Clinical Practice Specialist, Andrea Schmidt.
Welcome to this episode of Voices in Nursing. This is Dr. Vicki Good, Chief Clinical Officer for AACN, and I'm joined by my colleague and Clinical Practice Specialist, Andrea Schmidt.
Hi, welcome to today's podcast.
Andrea, we have both seen the impact that social determinants of health can have on patient outcomes, including adverse outcomes when vulnerable patients present to the ICU too late. We also know that patient outcomes can be related to the health of the work environment. Healthy work environments enable nurses to provide the highest quality of care and result in better staff retention, lower workplace violence, lower mortality, and fewer adverse events.
That's true, Vicki. If patients come from a more socially vulnerable population, how does the health of the work environment impact these patients? Socially vulnerable populations are a focus area for the research conducted by our guest today. Does a healthy work environment make a difference if you live in poverty, are a member of a minoritized or underrepresented group, or have limited English proficiencies? These were the questions our guest, Dr. Margo Brooks Carthon, sought to answer in her recent study titled COVID-19 Mortality Disparities Among Socially Vulnerable Medicare Beneficiaries Associated with the Quality of the Nurse Work Environment in U.S. Hospitals. But before we get started, Dr. Brooks, would you please introduce yourself to our audience?
Thank you, Vicki. Thank you, Andrea. I'm really excited to be here with you, with the audience. So as you said, I'm Margo Brooks Carthon. I'm a professor in the School of Nursing at the University of Pennsylvania. I'm the Associate Director for our Center for Health Outcomes and Policy Research. I'm the Director of the Bates Center for the Study of the History of Nursing. And my most proudest accomplishment is that I am a nurse. I've been a nurse for 30 years, which is incredibly, it's crazy to say, but I have been, and practiced for the majority of that time as a primary care and psych mental health nurse practitioner.
Margo, I was privileged to be able to meet you at the Academy in November, and I was kind of giddy getting to meet you after reading your work. What sparked your interest in studying the health of the work environments on the socially vulnerable patient population?
For sure. So my clinical practice, like I said, I've been a nurse for a long time. I practiced before coming back into, doing research and becoming a nurse scientist. And what I saw in practice really fueled my interest in problem solving and solutions. I feel like as nurses, we are all problem solvers. But as a nurse and as a nurse practitioner in community settings, I saw very frequently the care and the care outcomes for people who are socially vulnerable, economically disadvantaged, and minoritized. And I know that's not unique to me, but I do believe that nurses, we are in a particular space in the healthcare system where we know the healthcare system well. We're able to also form really important and impactful relationships with patients and families. And so as an NP, what I often saw is that while I was working in a fairly affluent area in New Jersey, we saw patients from everywhere. So we would have patients from Camden come or from other places that where material resources were not as robust. And I could see clearly and frequently that their outcomes following a course of treatment were not as robust. I could see that they might rely on medical transportation and would have to wait for 2 hours to get picked up from a medical appointment, or had a harder time affording medications, or more difficulties when we sent out a referral for specialty care. But I also saw that as a nurse that I could stand in as an advocate. And so I could get on a call with a colleague and help facilitate a faster appointment. I could work with pharma to get affordable or no cost medications. And I could get on the phone with medical transportation to say 2 hours is unacceptable. So being an advocate as a nurse is basically it's embedded in the ethos of nursing. And I don't know if I thought about it at the time, but I also worked in a setting where I was empowered. The physician I worked with respected me. I had a great deal of autonomy. He and I had great teamwork and communication, and that allowed me to bring my best self to work every single day. And it also inspired me to be able to advocate in the way that I did in my clinical practice. And it was actually that physician that I worked with in practice who encouraged me to apply for Penn's PhD program. And so that's just another testament to when you're working in a space where you feel supported, you really are able to continue to advance, problem solve, to, really widen the scale of what you're doing in your one local practice. And so you can think about that to nurses in practice, like how they can widen their scale from that one patient to the unit to the hospital when you're really focused or when your care is being delivered in a space where you are working in a healthy and supportive space.
That's great. And it was great that you felt empowered to be able to take it to the next level and start studying something that provided you such interest. So, would you be able to describe your study for our audience, particularly, what variables did you look at? How did you collect your data, overall aims, et cetera?
Okay, so let me start. I'll start broadly. So, everything I do as a researcher is to improve the outcomes of people that are socially vulnerable. So, at the top, you already described who those people are, people who are economically insecure or maybe marginalized due to race or ethnicity or limited English proficiency. So, we've already set the context for the people that I'm hoping to improve care for. But the question that is the thread that runs through this research is how do we maximize nursing care, right? How do we maximize the way nursing care is organized and delivered so that nurses are best positioned to provide maximal care to these patients who are often more complex due to clinical complexity and social needs, right? And so if I believe that nurses, because of their position, right? I saw this in my practice, but if I believe that they can do great things when well positioned, we have to make sure that their context is optimized. And I think that when nurses are stretched too thin because their working conditions are unhealthy or they're inadequately staffed or they're not supported by administration, I could go on. They're not able to bring their best selves and they're certainly not able to do more for people who need more. So that is any study that you read of Margo Brooks Carthon, that is probably underlying it implicitly or explicitly. So for this particular study, we leveraged what we already know. Like you said, we know that work environments and outcomes for patients are connected. And work environments for nurses, their outcomes too are connected to the work environment. So this current study looked particularly at COVID mortality, right? I think COVID is an interesting test case for whether or not our healthcare systems are prepared to care for the most vulnerable. So I'm going to use an example of Katrina. You all remember Hurricane Katrina?
Mhm.
And Hurricane Katrina tested the levees. The levees were already in poor repair. When the levees broke, the most vulnerable communities experienced the worst damage and the most loss of life. Okay, so I want you to think about COVID is our healthcare system, Katrina, right? It was a seismic stress test that happened. It was unpredictable. And so the question we ask is, were we ready? Was the nursing infrastructure intact? And could it handle the
Mhm.
pressure? And would people who are the most socially vulnerable suffer significantly more because of the stress to the system, right? So COVID mortality is the way we examine this question. And so we asked, number one, was COVID mortality higher among socially disadvantaged patients? So we weren't the first to ask that question because we saw really early in the pandemic that known disparities were highlighted and magnified. But we wanted to know, did in-hospital mortality for this particular patient population, was it heightened when cared for in hospitals where nurses themselves were reporting that this place is an unhealthy work environment. So I always think about nurses being the canary in the coal mine. When they tell us through surveys, because we survey nurses in hundreds of hospitals, that the work environment is poor, we then look at patient outcomes in those same settings, right? So we nest our patient data in those hospitals. And I also say when there's smoke, there's fire. When nurses say things are, hot, then it is. It really is. And so a measure for social disadvantage came from the CDC, and it considered elements such as income, education, housing, language status, minority status. And so we created a composite and we were able to rank patients from high to low social vulnerability. So let's say we had four categories. Category one was the least socially disadvantaged. Category four was the most socially disadvantaged. For our measure of the practice environment, Andrea, you asked about our variables. So our primary explanatory variable was the work environment is measured by the abbreviated practice environment scale. So that's a validated measure. And nurses are asked questions across several domains: staffing and resource adequacy. Do you have administration and nurse managers that listen to your concerns? Is there a high level of teamwork between you and physicians and you and other colleagues? And is there a clear philosophy of nursing practice that underlies your work? So those are some of the domains, and nurses are able to rank order, and we're able to take the average, and then we're able to look above and below to create categories for high, medium, and low practice environments. And so those are kind of the key variables that underlie that particular study. What we found is that we found a couple of things. We found number one, so this study looked at over 100,000 patients that were Medicare insured. We looked across 238 hospitals in New York and Illinois. And what we found is that the patients that were in the very least socially vulnerable, their average COVID mortality was 19%, right? So of all those patients, about, 1 in 5. For the most socially vulnerable patients, so that would be category 4, their average mortality rate was 26%, close to 26. So that's a 50% higher death rate for them in those two categories. So that was our first question. And that really kind of lined up with what the literature was saying, that there was a COVID mortality disparity for the most socially vulnerable. We then asked, well, were these socially vulnerable patients, the most socially vulnerable patients, more or less likely to be cared for in hospitals with healthy nurse work environments? They were the least likely, right? So the patients who were the most socially vulnerable were in hospitals where nurses actually reported that the work environment was the poorest, right? So they're least likely to be in the best work environments. So as you can imagine, the odds of death increase for any patient hospitalized in an unhealthy work environment. And so the work of like Linda Aiken and Dr. Karen Lassiter, who looked just generally at COVID mortality, found that any patient hospitalized during COVID experienced higher mortality when cared for by nurses working in unhealthy or unsupported work environments. We took it a step further because we wanted to know, well, what those death rates were, particularly for socially disadvantaged patients. And we found that when socially disadvantaged patients were cared for in the best work environments, their odds of mortality decreased by 20%. So that was powerful for us. And I'll say for a couple of reasons. We are interested in developing and identifying evidence-based solutions to reduce disparities, right? And so our interest in that for me is like, well, how do we systematize, like what is the best systems or way for us to improve the organization and delivery? And so when people ask me that, I said, improve your work environment, support
Right.
nurses, improve your work environments, you will reduce health disparities. So one of the things that we did in this study is that we created almost a counterfactual. We said, well, what if patients who were socially vulnerable were actually cared for in the best work environments? How many deaths would we have averted? So when we looked in general, we saw that if, the patients who weren't in the best practice environments had been 500, we estimated that 585 in-hospital deaths associated with COVID could have been averted if these patients had been cared for in the best work environments. And out of that
Mhm.
585, 291 of those deaths would have been among the most socially vulnerable. And so that to us was a aha moment in that, yes, all patients absolutely benefit from healthy work environments. Nurses themselves benefit from working in healthy work environments. The patients who benefit arguably the most are the ones who are the most socially vulnerable. And that makes me think about all the years I spent in practice when I thought about how can one person, one nurse, influence the outcomes of the patients that he or she sees. And in this case, it tells me that, the many, many nurses who are working across many,
Mhm.
many practices have so much power, have so much influence if we support them well.
Yeah, you're definitely singing from our songbook for sure. I mean, AACN went on the journey of advocating for healthy work environments back in 2005. Even before that, the board declared this as a strategic priority for us. So there's many different definitions of what a healthy work environment is. What factors did you identify that contributed most to a healthy work environment for these patients?
So for our study, we look at the work environment and the composite of the domains. And I think, and so those domains again are staffing and resource adequacy, administrative and leadership support, communication, collegiality, with the team, including physicians, having a nursing model of care to drive nursing care practice. What we didn't do was look at those domains individually. And so your question about which facet of the work environment was driving some of what we were seeing.
Hmm.
I think that's actually a next step question because we looked at the composite. So I do think that for intervention development, someone might say, well, that's a lot of things to focus on at one time, Margo. And so if you're talking to leadership and we have to focus on one of those five domains, like which one should we like focus our attention? So that is actually a next step question for us because one of the things, Vicky and Andrea, I'm so excited about the work that you're doing at AACN is because you're implementing change. And it's good and fine for us to identify these relationships between the work environment and outcomes, but it's high time that we start to develop organizational interventions and evaluate outcomes over time to really measure the degree to which we have improved patient outcomes, particularly for those patients who are more socially vulnerable. So I'm excited about the advocacy work you're doing. And in many ways, at least in my opinion, I feel like you're leading the charge, and that's exciting. That's exciting for me to see.
Well, and I think one thing that we've seen certainly in our research, and I would probably guess that you'll see the same thing, is that if people just work on the work environment, leaders, staff nurses, whoever it is, um, you don't have to focus on one area. As you focus on one area, the whole improves at the same time. So I think frequently we get that question, which
Hmm.
area should I start working on? And
Right.
we just say, start working.
Start working. I love it.
Yeah, go ahead, Andrea.
Margo, I really am. I want to say I'm shocked at the findings of your study, although I'm not as because unfortunately it is the state of healthcare, which I think was further exposed, during the pandemic, but it's still really hard to hear. And, that how many patients were impacted by the lack of healthy work environment and particularly the number of lives that could have been saved. It's just really kind of mind-blowing, honestly. But as you were talking, it made me start thinking about a couple of other things. Your study was mostly quantitative.
Hmm.
Was there any kind of qualitative data that was collected? Because I'm curious if there were any comments by the nurses of what they maybe thought, contributed to the lack of their healthy work environment. Because there's a couple things that come to mind for me, and I don't know if this was assessed, but when I think of professional development of the nurse,
Hmm.
if you work in an environment that's not healthy and you're not empowered to grow, do they even have time to even teach the nurses about what a socially vulnerable patient even is, right?
Hmm. So that is such a great question. And so I'm going to tease a paper that is coming out about this very topic. And you
Okay.
all have to have me come back and I'll talk about it in more detail. But so one of the things that I didn't mention is that this particular survey of nurses who reported on their work environment, this is many thousands of nurses. So I said that there were like 105,000 Medicare patients, there were 238 hospitals, but there are many, many thousands of nurses. So they report on their work environment, but we asked a text question. So this is open response. They're able to respond as little, as much, or not at all to the question, what helps or hinders your ability to provide care to patients who are socially disadvantaged? So this is to your question. This was a qualitative directed content analysis. And so by training, I am a mixed methods girl. Like I do quant, but I am deep into qual. And this particular uh, open text response is allowing us to get underneath like what are the things. So the work environment is a domain, but what about all of those process, what about other factors? And so I'll give you a couple of insights from what nurses told us helped or hindered. So one of the things, for example, that hindered their ability, particularly when caring for patients with limited English proficiency, was broken translation, equipment on the unit,
Mhm.
or all of the translators were fired, or there's no one available on the weekends, or, you can just imagine. So,
Mhm.
if the equipment is failing, or you don't have enough person power, or it takes too long to get on the language line, then these are all variations that could affect the quality of care. If you don't have enough social workers, if in some, one of the things they said is that where I work cares more for profits over patients. So if you have a sense that your organization doesn't really care about kind of the patients they're caring for, if the language line is broken or the equipment, if you don't have enough staff, I will say one of the most frequent comments is, we don't have time. You know, people barely understand what they need to do when they go home. I don't have enough time to teach. So, a lack of staffing, a lack of time, a lack of equipment, a lack of support, a lack of care coordination, those are things that came up frequently. And what we've done with that is we looked at what we called like high and low performing hospitals. So these are the hospitals that did really, really well and had better outcomes for socially disadvantaged patients. And we wanted to see, well, how do they differ from these other hospitals where socially disadvantaged patients didn't do as well? And so I would say that among the nurses, they gave recommendations about what they felt like they needed. And many of those recommendations really were like part and parcel of what we would define as a healthy work environment. Like,
Mhm.
give us some more support. But one of the things that they did say is we need more training, right? We need more training in how to deliver culturally appropriate care to people who are socially disadvantaged. And so I think that that's really important in telling. One, it was a telling self-assessment. I need more. It was also sometimes nurses were assessing their peers. They need more, right? Like they don't know how to care for people. And so there was some observation, there was some self-reflection. So sometimes these were activities at the organizational level that could be intervened on, sometimes at the individual or interpersonal level, right? And one of the things that we saw also was evidence of bias in some areas. And so all of these things, whether it be addressing our blind spots, so we all have bias. So addressing our biases, I say our in the collective, because it humanizes us to all recognize that there are places and people that we may not fully understand, and we come to this nursing as humans, and so we have to like deal with our subjectivities. And so more training, more lifelong learning. We all strive to be clinical experts, but can we also be experts in these social, like how to address these social needs? How do we integrate it? How do we advocate? I think all of these things came out of that study. I'll be so excited when it comes out and I can share it with you, but powerful to say the least. Really, really
Mhm.
powerful.
That's really insightful data, and
Hmm.
I love how it goes along so well, in aligns with the quantitative data that you collected. And I think there's so much that you can learn from all of those statements from the nurses.
Hmm. I do too.
Yeah, I look forward to seeing it. I think sometimes the qualitative data gives me more insight than just the numbers. So,
I agree. I like I said, I'm a qual girl and I love, that I and appreciate the skills that I've learned related to working with survey and large data, but I came to that piece of my research career having done a lot of qualitative work. And every study that I do, I'm always looking for either patient voices or nursing voices.
mhm,
And I think because we got so many, that was the thing. Like we got so many nurses who were really kind of sharing their experiences. I think many of us, when we are doing surveys, a lot of times it's on our phones. And so being able to, you can tell, like, you know, nurses were able to quickly respond, but they were really rich. And hearing those themes over and over and over again really led us to feel really confident that we were capturing the true essence of how nurses were feeling. And to your point, Vicky, I think those qualitative assessments, that's the meat on the bones, right? Like,
right.
yes, the work environment, but if we had just looked at the work environment, we never would have heard how many times nurses said the language line is problematic and the equipment is broken and they fired all the interpreters because those questions are not a part of it. And that, other than staffing, was the second most frequently commonly cited challenge, was a barrier to providing care to people with limited English proficiency. We never would have known that nurses said we need more training, we need more ongoing training in competencies in care delivery to socially vulnerable patients. So I've been thinking about, well, how do we take the work environment and how do we add in these components so that we're ensuring this holistic care for people who are socially vulnerable? Because it's probably that plus, right? Yes, assure that we have a healthy work environment, but there are also these elements that nurses that are informed by nurses that we need to be adding in as well.
Mhm. Yeah, and we found that even in units where staffing is not good, if the health of the work environment is good, nurses feel supported and they have a perception of having adequate staff. So it just is so crucially important. And along that line, I mean, advocacy has always been a huge um, piece of what we do at AACN. But one thing that we're looking at is how do we advise nurses in how to advocate? So what advice would you give direct care nurses, nurse leaders, or advanced practice nurses in how to advocate for themselves for a healthier work environment?
I guess I would say two things. One, I would underscore that no matter where you are, whether you're direct care, whether you're advanced practice nurse, whether you're a nurse manager, like these are powerful places, no matter where you are, to affect change. So whether you are a nurse manager or a direct care nurse, um, we all have a part to play. So that is empowering to me, right? Um, I also think, and this is my bias because I'm the director of a nursing history center, is that our history as nurses is so powerful when it comes to advocacy, right? And so when you know your history, it inspires you, right? Even in troubling and the most challenging times, I believe that who we are is baked into the ethos and the ethics of nursing, baked into our scope of practice and our standards is the care of people who are socially vulnerable. That makes me show up in my professional role every day saying, like, this is part of what I do. And so when I connect that real sense of identity and purpose, it helps to empower me, irrespective of now in my role as a nurse scientist working with healthcare systems. But I just recognize that power, right? And I know that sometimes we can feel deflated when we're not working in the healthiest work environments, and you can feel powerless.
Mm.
And what I've seen is that it can cause almost a sense of apathy and inertia, like this is how it is and nothing's going to change. And I get that. But I also feel like that apathy is the tool of the oppressor, right? Like if you give into the apathy, then you're right, nothing will change.
Right.
I am a half full glass kind of girl. And so I really, really believe in our power. I study historical nurses all the time. I think that they would not have dreamed that nursing is who nursing is today. When you think about our early foremothers in nursing and how we've advanced, when you think about that, like then we should be using this current place is to imagine the future we want for nursing and for healthcare delivery, and we need to act on it because they did, right? Like nursing,
Right.
we were trained in hospitals, we weren't trained in college or university settings. Everything we are now was probably outside of what they thought we could be. And that just tells me that 10, 20, 30 years from now, if we really lean into our roles, if we lean into the strategies that we know we can employ, if we allow ourselves to dream big, bold, transformational things, we can do big things, like in big
Mhm.
and bold things in nursing. We can address these health challenges. So I believe the context of care is important, but I also don't know that, I don't want us to feel like it's determinative. Like I work in a poor work environment and thus it can't change. It's like, how can I be the change agent? How can I be transformational? How can I say enough is enough and let me be a part of the solution? And I think that that would be my advice in terms of like, how do we advocate? Is really to recognize that we are a profession of pioneers, right? And we come from good stock. And so is
We definitely do.
That is very true. It makes me think of AACN's one of their previous slogans, which was using your bold voice.
hmm
And I really think that even if you work in the poorest of healthy work environments, or lack thereof, I should say, um, if you could just feel comfortable using your voice and you keep bringing the solution or potential solution to the forefront, I think at some point somebody's going to listen to you, especially if you're bringing evidence or some other sorts of standards. And when I think about the future, what you were just saying, like that's what I envision. I would love for every nurse to feel comfortable to use their voice and be empowered instead of sitting back and just, I don't want to use the word taking it, but taking it, right?
Mm-hmm.
So I love that. And so when I think about your research and everything that you found, um, it sounds like there's a lot of things that we were not prepared for in the pandemic, but that probably need to become the standard of care or the standard of the environment so that not only are we ready for, God forbid, another disaster or pandemic, but just improving the lives of that population in general,
Mm-hmm.
no matter what hospital you're at, no matter what geographic region you're at. What do you think those things are?
So I would say two things. We have to prepare for the next disaster because the next disaster is not, if, it's when, right? So COVID wasn't our first disaster. We'd had others previously. And so we had yellow fever, tuberculosis, AIDS, HIV, COVID. So these things happen and will happen. So I think one thing that we should focus on is improving the here and now. We have an opportunity now to take the lessons that we've learned and apply strategies that are corrective. I also think that, forecasting that there will be a next allows us to strengthen the levees before the hurricane, right? So
Mhm.
strengthen many of the elements that we talk about in the work environment may not require more cost, right? So a lot of times, but we have to recognize that systems are made. That means they can be remade, they can be revised, they can be tailored. That's empowering. And we can do the work now. We don't have to wait until the next disaster. And so that would be kind of my parting words is like, let's do the work. Let's do the work now. We have evidence. We have lots of evidence. And I guess the question now is, do we have the will? Right? Do we have the will? Do we have the urgency of now? Because a lot of times disasters create urgency. So can we use those lessons? Can we manufacture that fire in our belly to get the work done now to improve the lives of people who are socially disadvantaged? I wake up every day. That is my why. That is literally my why. Nursing is the vehicle through which I, improve this. There are many ways to improve the lives of people who are socially marginalized. Nursing is my calling. I believe in the power of nursing. Um, and so I'm really excited about the opportunity to think about, well, where do we go from here? How do we build on this work? How do we create powerful collaboration? So I think my why is like, how do we do this? But going forward is who do I do it with? And that's kind of
Mhm.
like the next chapter of this work.
Often recall several colleagues saying, never let a good crisis go to waste.
Yeah.
And,
I like
how do
that.
we learn from it and
Hmm.
pull forward? Well, Margo, this has been fascinating. I love reading your work, and
Thank
you
you.
have to let us know when that next paper comes
I
out because I
will.
definitely want to take a peek at it. But just thank you so much for sharing your time. I know it's precious and valuable, and we so much appreciate it.
It's been my pleasure. Thank you both for having me.
Well, and a special thanks to our audience for tuning in to this episode. We would also invite you to give us any feedback on this episode or future episodes. So please contact us at podcast@aecn.org. Thank you.
Thank you for listening to the American Association of Critical Care Nurses Voices in Nursing podcast, proudly sponsored by AACN's certification, offering specialty, subspecialty, or advanced practice board certification, with information available at www.aacn.org/get certification.